Hello, good morning. Today we are going to discuss the indications, advantages, and use of X-rays in otolaryngology. At the outset, let me warn you that the indications for X-ray in the field of otolaryngology is actually slowly beginning to wane. In fact, actual indications are very, very, very few. But still, I need to cover this topic because this is actually the common questions are asked from this subject, and x-rays are displayed during the examination, and students are expected to answer questions on the basics of radiology in ENT. So today our focus is going to be x-rays in ENT. So let us go into the actual indications of x-rays. As I've been telling you, reiterating, actual indications are very few, and the foreign body and the aerodigestive tract are shown better in X-ray because X-ray is freely available even in the remotest part of the country, and it is easily done. The pictures can be is processed very fast, and you can get a report in a short span of time. So, some of the common indications for X-ray in otolaryngology is to identify a radiopaque foreign body, or sometimes a radiolucent foreign body may show up in the aerodigestive tract. Then to assess the subglottic air column in patients with stridor, and to clearly ascertain where the trachea is, the position of the trachea can be ascertained by soft tissue neck X-ray. And then fractures involving the nasal bone, so that you can do a skeletal survey, and fractures involving the facial bone, nasal bone, all the facial bones show well in X-rays. So fractures involving facial bones can be clearly delineated in a facial bone X-rays. Now, there are some advantages which is unique to X-rays. It is cost effective. It is easily available throughout the country. It can be rapidly performed even under emergency situation. And in fact, trained manpower is available even in the rural settings, unlike CT imaging. And now, the commonest X-ray the student is supposed to interpret happens to be the Waters view of the paranasal sinuses. And this diagram shows exactly how the patient should be positioned. The patient should be supine, then should be made to lie down prone on the table with the X-ray plate facing the face, and the face should make an angle of 45 degrees with the X-ray plate, and the tube should be focused at the level of the external occipital protuberance. So that is actually the radiographic baseline. So this is the X-ray tube, position of the X-ray tube. The patient is prone with the head making an angle of 45 degrees with the X-ray plate. The chin should actually be resting on the X-ray plate. This is how a X-ray Waters view or occipito-mental view, which is other term used to indicate this X-ray, is occipito-suboccipito-mental view. So this X-ray, even though otolaryngologists and rhinologists don't depend on Waters view anymore, CT has totally taken over, but still for the sake of completion, and this is the commonest X-ray which is being taken these days. So this is the commonest view, Waters view taken, because it has a unique advantage where it will demonstrate almost all the sinuses. The patient is actually made to sit or lie prone facing the X-ray plate. In old individuals who are unable to sit, they may be even be forced to lie down in a prone position. If the patient is comfortable being seated, the patient can be made to sit facing the X-ray plate, and the radiographic baseline, which is actually the line drawn from the external occipital protuberance to the mentum, and this is tilted so that it will make a 45-degree angle at the sagittal plane. The mouth should be open because through the open mouth, sphenoid sinus will be visible. So to ensure visibility of the sphenoid sinus, mouth should be kept open. The petrous apex lies beneath the floor of the antrum. This position ensures that the petrous apex is not obscured by the maxillary antrum. So the petrous apex will be clearly visible below the floor of the antrum if you exactly make a 45-degree angle. If your chin makes a radiographic baseline makes a 45-degree angle with the X-ray plate, then the petrous apex will be pushed down and it will be seen below the level of the floor of the antrum. So that is the most important uh, salient aspects of X-ray sinuses Waters view, otherwise known as suboccipito-mental view. Here, this is actually typically the X-ray of the nose and sinuses. You're seeing the X-ray. This is otherwise I have been repeating, re-stressing that this is the occipito-mental view. And the other X-ray which you take to visualize the paranasal sinuses include occipito-frontal view or calval view. This view brings out the frontal sinus very well. It delineates and clearly demonstrates the frontal sinus very well. Supposing you want to exclusively image the frontal sinus, it is better to take the occipito-frontal view or calval view. Then there's another view. These are very rarely done. Submento vertical view or Hitz view, and then lateral view of the skull, and then 39 degrees oblique view, that is the Rees view. All these views except for the Waters view and Calvel view are not at all done these days. I'm just enumerating all these things for the sake of completion. This is actually the classic X-ray of the frontal sinus, where the frontal sinus is indicated by the arrow. This is actually the frontal sinus. You look clearly at the scallop margins. In the sequence of other events, I'll be showing you the loss of this scalloping. What to infer if there is loss of this scalloping. If there is loss of this scalloping, see, you see this curvature. If the scalloping margin is lost, it indicates a frontal mucosal, and this happens to be the orbit, right orbit, left orbit. This is the maxillary sinus. You see the maxillary sinus indicated. This is the nasal septum. These are the nasal cavity. You see a prominent inferior turbinate here. I'm showing it to you with my arrow. This is a prominent inferior turbinate on the left side, and then this is the maxillary sinus on both sides, and here this is where the petrous apex will be shown below the floor of the maxillary antrum. This is the maxillary antrum. The petrous apex will be shown here like this. So this is the sphenoid sinus which you see through the open mouth, and this is the tongue sphenoid sinus. So this is actually how your occipito-mental view or Waters view of X-ray paranasal sinuses looks like. Let's go to the next one. So here in our previous page, we saw the normal X-ray of the paranasal sinuses. Let us see some of the pathological aspects which X-rays of the paranasal sinuses or Waters view or suboccipital mental view could demonstrate. So here, this picture shows this is actually the frontal sinus. You see this antrum when compared to this one is really hazy. Supposing the radiolucency or opacity of the antrum is always compared to that of the orbit. So more or less the orbit and the antrum should have the same radio density. So if you compare the right orbit along with the right antrum, the opacity is more or less the same because the air-filled cavity and the opacity is more or less the same. Whereas here, if you see compare this radio density with that of the orbit, you see the orbit is slightly less dense than that of the maxillary antrum, which is hazy. So this antrum is hazy antrum. Hazy antrum indicates what? There is some collection of fluid or some of the blood or some of the material within the maxillary sinus antral cavity. And this is the nasal septum. This is the sphenoid sinus which is filled with air. That is why it is shown in black. And this is the orbit. This is the frontal sinus. So this is actually a classic feature or a picture which shows a hazy left maxillary antrum. But you should also look for any enlargement of the maxillary antrum. The size of the maxillary antrum, you should always compare the size of the maxillary antrum with that of its counterpart on the other side. So here there is actually they look more or less of the same size. So there is no enlargement of the maxillary sinus antral cavity. And then the frontal sinus again shows scalloping of the margins. So when there is scalloping of the margins, see this is the scallop margins. You see the bumps. So these bumps are nothing but scallop margins. If the presence of scalloping margins in the frontal sinus shows the frontal sinus is free of any fluid or mucosal. So when the scalloping is lost, when there is no scalloping in the frontal sinus margin, it indicates the presence of mucosal. So the common question which is asked in your oral examination is, tell me the classical feature of frontal sinus mucosal which is demonstrated in X-ray paranasal sinuses water view. So you need to tell that loss of scalloped margins. That is the first point you should say. And then haziness or opacity of the frontal sinus cavity. So that is the second answer you should give. Let me go to the next one. Here, this X-ray paranasal sinuses again, Waters view shows the maxillary antrum is again opacified. You compare it with the opacity of the right orbit, it is opacified. But when you compare the size of the maxillary antrum on the right side with that of the left side, there is a definite expansion. So this maxillary antrum is larger than that of the left. Right maxillary antrum is larger than that of the left. And then again, you can see there is a destruction of the medial wall of the maxillary antrum. So you see this wall is destroyed and the contents of the maxillary sinus antrum is seen protruding into the nasal cavity. So there is a erosion or destruction of the medial wall. Again, see the superior wall of the maxillary antrum forms the inferior wall of the orbit. So you see the inferior wall of the orbit is eroded and the same tissue or contents of the maxillary sinus could be seen protruding into the orbit. So there is probably this patient is suffering from malignant lesion of the maxillary sinus with erosion or destruction of the medial antral wall or medial wall of the maxillary sinus and extension of the margin of the nasal cavity, and then the superior wall of the maxillary sinus is again eroded, so ensuring that the contents or the malignant tissue from the maxillary antrum has got into the orbit. And another common question which the examiner, the old timers used to ask by just projecting these x-rays, can you tell me whether the pterygoids are involved in this patient? Since it's a malignancy, involvement of pterygoids is one important aspect which you should consider before you manage the patient. So you should say whenever there is involvement of pterygoid by malignant tissue or malignancy per se, will cause the patient to have trismus. Difficulty in opening the mouth is known as trismus, and patients with involvement or erosion or erosion of the pterygoid plot or involvement of the pterygoid musculature, the patient will have trismus and the patient will not be able to open the mouth. But here, this patient whose X-ray has been projected definitely has an open mouth, and you can see the sphenoid sinus through the open mouth. So the fact that you are seeing the sphenoid sinus and the fact that the patient is able to open the mouth during the radiographic procedure tells us that the mass has definitely not extended into the pterygopalatine fossa. Neither it has eroded the pterygoid plates nor it has involved the pterygoid musculature, because this patient does not have trismus. Next one, I've been telling you again, you should always compare the size of sinuses with that of its counterpart. So here you see in this X-ray paranasal sinuses Waters view, the frontal sinus is not seen. The frontal sinus is not seen. So this is actually agenesis of frontal sinus. So this patient does not show any development of frontal sinus. But here you see a suture line. This is actually a primitive suture line which is present in embryos and infants. Is known as a metopic suture. The persistence of metopic suture goes along with non-development of frontal sinus or agenesis of frontal sinus. I repeat again, if you see a metopic suture, you are sure that the frontal sinus has not developed in that individual. So this is aging. In all patients with agenesis of frontal sinus, you see the primitive metopic suture line. That is what you see here. And then here, if you compare the maxillary antrum on both sides, The size of the maxillary antrum again looks pretty small. So this is actually a hypoplastic maxillary sinus. Then if you observe the walls of the maxillary sinus, they definitely appear thickened. Then that even the medial wall of the maxillary sinus, which is supposed to be thin, the superior wall of the maxillary sinus again, which is supposed to be thin, is thickened in this X-ray paranasal sinus water tube. So this is a feature of hypoplastic maxillary sinus. So this X-ray shows you the hypoplasia involving the maxillary antrum as well as agenesis of frontal sinus. This is actually a variant of the anatomical development. So you should not consider this to be a pathological entity. This is a normal variant rarely seen in some individuals. So this is a hypoplastic antrum along with agenesis of frontal sinus. And here again I am showing you another X-ray paranasal sinus water view where you see two small air cells here, and you can mistake these air cells to be frontal sinus. But here you see a metopic suture line. Whenever you see a metopic suture line, you is indicated by this black arrow. Whenever there is a metopic suture line present, it goes hand in hand with the agenesis of frontal sinus. Then what exactly are these two sinuses? These are nothing but enlarged anterior ethmoidal air cells. These are nothing but enlarged anterior ethmoidal air cells. These two are enlarged anterior ethmoidal air cells. And then the metopic suture invariably is present in X-rays of all children until the age of 6. So after the age of 6, the metopic suture simply vanishes or gets ossified. So I repeat again, this metopic suture is a normal occurrence in X-ray sinuses taken in all children under the age of 5 or 6. And then metopic suture is always present in patients with frontal agenesis. And here, in addition to all these features, don't forget to compare the opacity of the maxillary sinus antrum with that of the corresponding orbit. Here, this antrum appears to be hazy, and the sphenoid sinus is seen with the mouth open, and you see the tongue. So this hazy maxillary antrum indicates a chronic or acute sinusitis. The next picture I'm going to show you is the Caldwell view. How to take a Caldwell view X-ray. Caldwell view is nothing but occipital frontal view, also known as Caldwell view. So this is actually, as I have told you previously, this gives us useful information on the frontal sinus. Here in this X-ray, the patient is again made to sit on the X-ray plate is held in front of the face. The radiographic baseline is tilted in such a way that it makes an angle of 15 to 20 degrees upwards. The baseline makes an angle of 15 to 20 degrees upwards along with the X-ray plate. So the X-ray beam is actually centered half an inch above the external occipital protuberance. So the X-ray beam is centered here. That is half an inch above the external occipital protuberance. This is how you position the patient to take a X-ray of occipital-frontal view or Caldwell view. Just I'm holding this slide for some time so that you will have a better idea of how the patient is positioned while taking a X-ray paranasal sinuses, occipital frontal view or Caldwell view. Let us go to the Caldwell view, how exactly a Caldwell view will look like. So here you see the frontal sinus more clearly displayed. So you see the frontal sinus, see all the curvatures, frustrations or scalloped margins, and then the frontal sinus is displayed very clearly. There is no distortion. And then here the petrous apex is here. So the petrous apex in fact will obscure the maxillary antrum, and this is the petrous apex and this is the petrous apex obscuring the maxillary antrum. So this view actually, you should take this view to take template of the frontal sinus, so that if you want to perform a external frontal sinus surgeries where you are going to remove and replace the outer table of the frontal sinus, you need to have a template to prepare the bone patty. So this template preparation is made easier when you take from X-ray paranasal sinuses cal value, so that the frontal view will be totally clearly demonstrated, and you can use this X-ray as a template to create the bone patty when you attempt to remove the anterior wall of the frontal sinus. So enlarged adenoid is the next thing which we are going to see. Here, this is an X-ray of the skull taken in a child with the head tilted backwards. So here, this asterisk, you see, this is the adenoid tissue. This is actually the enlarged adenoid tissue you see here. So the nasopharynx is actually this area. So the nasopharynx is narrowed. So the air from the nasal cavity will find it difficult, or rather will face obstruction here at the level of the nasopharynx because of this bulging adenoid tissue. I think you should be able to appreciate this adenoid tissue. So in an infant, it is not possible for you to do a nasopharyngeal examination in outpatient setting, but still clinically, if you suspect that this child could be having an enlarged adenoid, the best practice will be to document your finding. The best way to document is to take a radiology, because it is very difficult to perform CT scan on a child, whereas it is easier, comparatively easier to perform radiological evaluation of a child. So enlarged adenoid could be seen in the lateral view of the skull with the head slightly tilted backwards. So then there is definitely a narrowing. You can see a funnel shaped nasopharynx. In other words, you see a funnel shaped nasopharynx with enlarged adenoid tissue. So in a normal individual with a normal size adenoid, this nasopharynx is more or less will be tubular, or rarely it can have a hourglass appearance. But this funnel shaped appearance is classically funnel shaped nasopharyngeal air column. It's classically seen in children with enlarged adenoid tissue when you take a X-ray skull lateral view with head tilted slightly backward. So you need to specify to the radiologist that when you write X-ray for adenoid, you should specify, you should say X-ray lateral view of the skull to visualize adenoid. So if you specify that only, they will give this tilt, tilt the head slightly backwards, so that adenoid will be clearly visible. The next topic which you are going to see is the X-ray skull lateral view. So the X-ray skull lateral view is again very rarely performed these days. The patient is actually seated. The sagittal plane is actually parallel to the X-ray film. You see, this is the sagittal plane and this is the X-ray film. So the sagittal plane is more or less parallel to the X-ray plate, and then the beam is centered along the middle of the nasal cavity. So the beam is centered along the middle of the nasal cavity. The radiographic baseline is placed horizontally. So here the roof of the antrum, or sometimes the middle of the antrum. So the ideally X-ray beam is centered in the middle of the antrum, so that the lateral view of the skull will be displayed. So I'm leaving this image for some time so that you can take a screenshot or a snapshot or image shot for your later reference. And again, let me tell you, all these videos I present are of high definition or 4K. So it is ideal if you could watch these videos in a larger screen, preferably on your laptop, desktop, and it is best viewed on your TV, large screen TV. You can screencast your entire video lecture onto your large screen TV, so that you can enjoy the entire lecture on a 4K resolution. Nothing like 4K resolution, which will bring out all the minor details. The letters will be viewed beautifully. The audio also will be very good. So here, this is how you take a X-ray skull lateral view. I repeat again, the patient is seated. The sagittal plane, this is actually the sagittal plane. The sagittal plane of the skull is actually parallel to that of the X-ray film. And the radiographic baseline, which happens to be the line between the infraorbital rim and the external auditory canal. So that baseline is actually horizontal, and the X-ray beam is centered in the middle of the maxillary antrum. And then this is how the X-ray skull lateral view will look like. So here, this view really helps in distinguishing the various pathologies involving the frontal sinus. For example, here this is the only plain X-ray view that will give you both a good view of both the anterior. This is the anterior table and the posterior table of the frontal sinus. So this is the only. I repeat again, X-ray skull lateral view is the only plain X-ray view. And I'm not talking about CT scan. Let me warn you. I'm talking about X-ray sinuses, paranasal sinus. The only X-ray paranasal sinus view that will give a good visualization of both the anterior and posterior tables of the frontal sinus is the X-ray skull lateral view. And here, this is the maxillary sinus antrum. And here, this fluid level of the maxillary sinus antrum can be clearly seen if the patient is suffering from sinusitis. When there is accumulation of fluid inside the maxillary antrum, the level of the fluid will be clearly seen in the X-ray sinus lateral view, and you see excellently, you see the soft palate, and this view gives a good view of the nasopharynx as well as the palate. So this is the nasopharynx. So any nasopharyngeal mass can be clearly seen in the X-ray skull lateral view. I have already told you the fluid levels in the maxillary antrum can be clearly demonstrated only in this view. Then, if you want to study the soft tissues of the neck, you will have to clearly specify to the radiologist that you need to cover the soft tissue neck lateral view. So you are more interested in the soft tissue neck. So when you give out this detail, the radiologist will ensure that the adjustments to the exposure are made such a way that the soft tissue will be delineated better. So this is actually the X-ray soft tissue neck lateral view. This view is commonly performed to identify a foreign body in the air passage or food passage, and then it is very useful to assess the subglottic air column, and then it is used to assess the position of the tracheostomy tube inside the, whether you need to ascertain when you do a tracheostomy. After the tracheostomy, you don't know whether the tube has slipped out of the trachea. If you do X-ray soft tissue neck lateral view, it will clearly show the position of the tip of the tracheostomy tube, whether it is in the trachea or whether it is in the soft tissue away from the trachea. So this X-ray soft tissue neck lateral view is a must for all these conditions. I repeat again, X-ray soft tissue neck lateral view will help you to identify the presence of foreign body in the food passage or airway. It is again used to assess the length of the subglottic air column, and then it is also very useful in assessing the position of the tracheostomy tube. Now next, again I have already told you, for X-ray soft tissue neck and lateral view, it's more commonly used to assess or look for the presence or absence of foreign body. Here in this X-ray, this is actually X-ray soft tissue neck anterior-posterior view. So the anterior-posterior view X-ray, this here you see a spherical foreign body. This spherical foreign body is projecting or seen on the X-ray as a face-on view. You are seeing the face of the spherical foreign body. Since it is again radio opaque, so you see there is a radio opaque foreign body showing a face-on view. And then here, the presence of this face-on view really tells us this radio opaque foreign body, probably a coin, is in the food passage. It is not in the air passage, because if this foreign body would have been in the air passage, it will not show you a face-on view in the X-ray soft tissue neck AP view. It will show a lateral view. It will show you an end-on view. So if the coin is turned like this, so let me demonstrate this with a coin so that you will have better understanding. Here, for better understanding, I'm showing you the coin. This is the face-on view of the coin. So this coin, as you see in the picture, will be shown as a face-on view. In X-ray soft tissue neck AP view, if the coin is present in the air passage, this is the view we will be seeing. This is the face-on view. And then if it is in the airway, the AP anteroposterior view of the X-ray soft tissue neck will show a coin like this. You'll be seeing the coin like this. So this is the end-on view. So If it's like this, if you see the coin like this, it is in the food passage. If you see the coin like this in this view, if you see a coin like this view, like this in this view, send on view, it is in the air passage, because the esophagus is slit horizontally, opens horizontally, so the coin can enter only like this, whereas the airway is slit vertically, so the coin will enter the airway like this. So this is the importance of this X-ray, so that you should know by seeing the X-ray where exactly the foreign body is present. So because the foreign body in the airway is an emergency situation, you need to remove it immediately. Whereas if the foreign body is in the food passage, you can take 3 or 4 hours, get the patient ready, and you can do it in a controlled condition. You can remove foreign body if it is present in the food passage, but in the air passage, it is a real emergency. Then here you see in the lateral view of the soft tissue neck lateral view, you see the same coin in the lateral view will be on an end-on view. You will see it in an end-on view. You will see the lateral view or side view of the coin when you do a X-ray soft tissue neck lateral view. So if the coin is present in the food passage, you see the side-on view, and then the coin is just below the level of the cricopharynx. So this is exactly, you can count the vertebra. C6 level is the cricopharynx. So this is the sixth vertebra, just at the level of the cricopharynx, the foreign body is held. Next here, let me show you another foreign body. Here again, this is an X-ray soft tissue neck lateral view. You see a foreign body here, radiopaque foreign body, a linear foreign body here. So this lateral, if you see a foreign body in the lateral position of the neck, this is more or less in the pyriform fossa. So a radiopaque foreign body is seen in the left pyriform fossa. Let me warn you that pyriform fossa is a very common area or very common spot where foreign body gets lodged. This is most probably a linear foreign body, radiopaque foreign body, could be a bone. So next is, I'm going to show you another X-ray where you see a open safety pin. So in this picture, you see a X-ray soft tissue AP view showing a open safety pin. So this safety pin is at the level of the cricopharynx, and this removal of the safety pin is a real challenge. When you remove, there will be a certain amount of trauma to the mucosa. So you need to be very careful. And there are specialized forceps for removing this foreign body. And you should ensure that you hold the sharp portion, tip of the safety pin, open pin, while you remove, so that when you guard the tip of the safety pin, it is not going to cause any trauma to the mucosa. You ensure that you hold the safety pin. The sharp portion of the safety pin should be held within the jaws of the forceps which used to remove the foreign body. Initially, those days, they used to use specialized forceps known as Clerf Arrow Smith forceps. This Clerf Arrow Smith forceps is actually a double forceps which you can use to close the open safety pin and remove it. So this is again point of historic interest, because right now this instrument is not that popular, but for the sake of completion, I'm telling you, in historically, in olden days, they used to use this Clerf Arrow Smith foreign body removing forceps. They will use it to close the safety pin before attempting to remove it. And the next is again another X-ray which shows an open safety pin. X-ray soft tissue neck AP view. Again, next X-ray I'm going to show you is an X-ray paranasal sinuses Waters view. And here you see there's a swelling inside the nasal cavity. There's a swelling and you see air shadow inside. Whenever you see a swelling with a central air shadow, you always think in terms of abscess. So whenever you see a swelling with a central air shadow, you always consider abscess. So this patient is having a septal abscess. And then both these maxillary sinuses are showing haziness. So you always compare the opacity of the maxillary sinus along with that of the orbit. It at least appears on the picture a little bit hazy when compared to the orbit. So here you see the opacity of the maxillary antrum. And how come when you okay, there is abscess there, how come air is inside the abscess? This air could be probably released by the gas forming organisms, anaerobes, which can cause the presence of air. And whenever there is abscess, when what happens is the cartilage, nasal septal cartilage, derives its nourishment from the lining pericardium. So whenever there is an abscess on both sides of the nasal septum, it will strip the pericardium away from the septal cartilage. So this septal cartilage will lose its nourishment from, because it does not have a blood supply. It derives its nourishment from the pericardium, and the stripping of the pericardium will really compromise the blood supply to the septal cartilage, so that dissolution of the septal cartilage will occur. So if this condition persists, if you allow the patient to persist with septal abscess for 48 hours, 36 hours is the maximum, the septal cartilage will undergo liquefaction necrosis, and the patient will lose the dorsal support of the nasal cavity, and these patients will land up with a big snout deformity. So the nose, when the cartilage is destroyed, will more or less resemble the nose of a pig. The next X-ray I'm going to show you is again X-ray sinuses, water's view or occipital view. It's a radio opaque shadow inside the nasal cavity. More or less, this could be a radio opaque foreign body. So in this case, since I knew it's a rhinolith, so I just marked it as a rhinolith. But if they project a similar X-ray to you, you need to give out a differential diagnosis. And the most common differential diagnosis you need to give is a foreign body. And the next only should be the rhinolith. The first most common things are common. So here, since I knew it, I treated this patient, I knew it's a rhinolith. I operated on this patient, so I knew it's a rhinolith. So I just marked it as a rhinolith. But when this X-ray, similar X-ray is projected to you on the examination, or you give out a differential diagnosis, you first say, what is the X-ray view? This is X-ray assigned as Waters view or suboccipital view, and this view is taken with the mouth open, and you see the sphenoid sinus through the oral cavity. And here, when you compare the opacity of the maxillantrum along with the orbit, is more or less the same. So here you see a radiopaque shadow in the right nasal cavity. So most probably it could be a foreign body or a rhinolith. So next X-ray is again X-ray soft tissue neck lateral view. So you see, rarely you can see the tonsillar enlargement in the X-ray. So supposing you are given this X-ray, you should not get confused. You should not feel that this is a tumor or mass. This is actually an enlarged tonsil seen in the lateral view. This is the incidental finding. Let me tell you, whenever you do X-ray soft tissue lateral view, neck lateral view to identify a foreign body or to rule out a foreign body in a child, if you see this bulge, if you see this soft tissue shadow, don't mistake it for a foreign body. It could be an enlarged tonsil being shown inside the X-ray soft tissue neck lateral view as a mass. So it is always imperative on your part to do a clinical examination. If you see the tonsils enlarged, so in all probability this mass could be a tonsillar mass. The next X-ray I'm going to show you is acute epiglottitis. If you do a X-ray soft tissue neck lateral view, you see a shadow like this. This is the epiglottis area. It resembles more or less like a thumb. See the thumb. It looks like a thumb. So I'm showing you my left thumb just to show how a thumb will look like in the X-ray. So this thumb sign indicates acute epiglottitis. So when you see this thumb sign, it indicates acute epiglottitis. So this patient is suffering from acute epiglottitis. So that is the reason why this patient is having a thumb sign. The next X-ray I'm going to show you is again X-ray soft tissue neck lateral view. Here there is a clear-cut widening of the space in front of the cervical vertebra. This is the prevertebral. You use the term prevertebral soft tissue widening to indicate the enlargement the tissue in front of the cervical spine. So how much of increase in the thickness should be sufficient for you to brand it as a prevertebral soft tissue widening? To say that there is a prevertebral soft tissue widening. The widening of the prevertebral tissue should be more than half the size of the corresponding vertebra. I repeat again, for you to brand that there is the presence of soft tissue, prevertebral soft tissue widening, there should be a widening of the prevertebral soft tissue of more than half the size of the corresponding vertebra. So this is the body of the vertebra, half the size of the body of the corresponding vertebra. So here there is definitely widening of the prevertebral space, because this area extending from here to here is definitely more than half the size of the body of the corresponding vertebra. So there is prevertebral soft tissue widening. The next point which you are looking is the curvature of the cervical spine. So there is straightening. Normally there will be a lordosis of the cervical spine. Here there is straightening of the cervical spine. This is because of the irritation of the prevertebral muscles. The irritated prevertebral muscle has a tendency to contract and it straightens the spine. So the straightening of the cervical spine, also known as ramrod spine. So this is actually due to the prevertebral muscle spasm as well as the paraspinal muscle spasm. And then you see a fluid level and a gas shadow above. So why this gas occurs? This is probably a retropharyngeal abscess, because there is definitely a air column above. This air column is caused by anaerobic organism generating gas, or in other words, the patient who is not able to swallow because because of the pain, he tends to swallow little by little, and gas tends to air he tends to gulp in air when he attempts to swallow saliva, and this air has a tendency to collect above the uh, swelling, and it could be seen as a gas. Because of the presence of cricopharyngeal spasm, air will get accumulated and you will see uh, air shadow. But commonly this air shadow is caused by anaerobic gas forming organisms. The next X-ray I'm going to show you is again X-ray soft tissue neck lateral view. Here you see there is a swelling in the floor of the mouth. You see the floor of the mouth appears to be down or swollen. So this is most commonly due to Ludwig's angina. And here you see the tongue also happens to be pushed backwards. The tongue is pushed backwards, and you need to watch out for this air column, because this swelling can very easily enlarge in size and it will cause obstruction to the air column here. So you need to keep a watch out on these patients with Ludwig angina for airway obstruction. So this commonly occurs because the tongue here has a tendency to fall back and obstruct the airway. So the first thing you need to do in these patients to secure the airway by putting in an oral airway tube, so that you prevent the falling of the tongue backwards, and then you start the treatment. This is actually a Ludwig's angina patient, which is clearly demonstrated in the X-ray neck, soft tissue neck lateral view. Then here I have again this X-ray. I think I have shown you already. The repetition, sorry. And this again a thumb sign, the enlarged epiglottis, thumb sign. Then next we'll come to the contrast X-ray or the barium X-ray. Here the patient has, this is actually a barium swallow X-ray, anteroposterior view, AP view of the barium swallow. Here you see the normal barium accumulating in the pyriform fossa, going through the cricopharynx into the esophagus. Here there is no barium at all. So the arrow, the green arrow, shows you the absence of barium in this area. So this absence of barium in the pyriform fossa is commonly due to presence of mass in the pyriform fossa, preventing accumulation of barium. So this patient is most probably having a mass, a malignant mass in the right-sided pyriform fossa. So there is a non-filling of the right pyriform fossa. There is absence of barium in the right pyriform fossa, indicating a malignant lesion in the right pyriform sinus. The next X-ray I'm going to show you here, again a barium swallow, a EP view. So you see the normal filling of both sides of the pyriform fossa. This is the postcrical region, but here you see this is actually the narrowing. This is the dilatation, this is a narrowing. So this narrowing is caused by the constriction at the level of the cricopharynx. So here barium is accumulating and there is a narrow. This is probably a stricture just below the level of the cricopharynx. So this stricture is causing obstruction to the flow of barium. So there is a collection of barium above. So there, here you see the obstructed area, and then there is a dilatation below the level of the obstructed area. So this is classically a stricture esophagus, which could be due to corrosion or due to malignancy. And then here, this is again X-ray barium swallow lateral view. So here you see multiple level of constrictions here. 1, 2, 3. These constrictions, in fact, are considered to be normal because they more or less correspond to the normal constrictions which are present in the esophagus. Sometimes the peristaltic wave which pushes the barium into the X-ray down can cause this apparent appearance of constrictions. So presence of peristalsis or presence of normal constrictions which are seen in the esophagus because of the compression caused by the trachea, compression caused by the arch of the aorta. So these things can cause a natural narrowing of the esophagus in all persons. So this multiple constrictions when you see in a barium swallow X-ray lateral view, you need not worry when you see multiple constrictions. It could be probably due to peristaltic wave or could be the normal constriction caused by external compression due to what do you call the tracheal compression, bronchial compression, aortic arch compression, left atrial compression. All these things will manifest as uh, narrowing in the esophagus in a barium swallow. Again, usually when you take a barium swallow lateral view, you need to take a left lateral oblique view because you need to remove the left atrium from creating a obstruction to the visualization of the esophagus. So you need to, whenever you want to view X-ray, contrast X-ray of the esophagus, you always take a barium swallow left lateral oblique view. So whenever you want to take a X-ray barium swallow of the esophagus lateral view, you need to ensure that you need to take this view, left lateral oblique view, because this view really ensures the visualization of the esophagus free from the cardiac shadow. Here you see in this X-ray, there is a filling defect in the middle third of the esophagus. Definitely there is a filling defect followed by dilatation of the esophagus below. So this feature classically tells you that there is a malignant stricture in this area. The next X-ray I'm going to show you again, X-ray barium swallow AP view. Here you see the barium filled here. There is a lower esophageal sphincter spasm here. So the totally the esophagus is filled with contrast. It more or less looks like a bird's beak or a parrot beak because of the constriction here. Barium has not flowed. There is a dilatation, proximal dilatation of the esophagus. This is actually a classic feature of achalasia cardia. So here in achalasia cardia, there is a spasm of the lower esophageal sphincter and there is accumulation of barium in the proximal segment of the esophagus, causing enlargement of the esophagus with a narrowing in the lower end, resembling a parrot's beak or a bird's beak. So this is a feature of achalasia cardia. Again, this I have already shown you enlarged tonsil. Sorry for the repetition. Here, this is the X-ray of the mastoids. Whenever you want to take X-ray of the mastoids, you should take X-ray of both sides because you need to compare one side with the other to ensure that the pneumatization is proper or not. So you, before commenting on the pneumatization of the mastoid air cell system, you need to compare it with that of the other side. So whenever you are ordering an X-ray of the mastoid, you always order X-ray mastoids both sides. So you say X-ray mastoid loss view both sides. So here you see this is the petrous apex. This is the petrous apex. This is actually the air cell cyst external artery canal. Around it you see the air cells. Here this is the cholestematous cavity which is seen in the green arrow. So you see this is the cholestematous cavity in the green arrow and this is actually the operator cavity which you see in the brown arrow. So this is actually cavity in the petrous apex. This is actually the operated cavity. This is it's a cholestematous cavity. So here again, this is the cholestematous cavity. you see the operated cavity. So cholestematous cavity will have hazy material inside the cavity, whereas operated cavity will be clear, and the margins of the operated cavity will be sclerosed, whereas the margins of the cholestematous cavity will be irregular. So this is a cholestematous cavity, this is the operated cavity. This is a pneumatized mastod, well pneumatized mastod. You see the normal air cells all over the mastod area, and this is actually the sclerosed mastod. So this is actually Petrus apex. This is external. This is external. You see virtually no pneumatization at all. There is no pneumatization of this mastod bone. So this is again another common question which is asked in your orals. Differential diagnosis of a cavity in the temporal bone. If it is going to be a cholestematous cavity, radiologically, this cavity will be surrounded by a rim of sclerosis. In a granulomatous cavity, again, another differential diagnosis for cavity is a granulomatous cavity or a granulation cavity. There will be a hairline appearance. And then the third is the operated cavity. Definitely the patient will be able to give a previous history of mastoid surgery, and the margins of the cavity could appear irregular, may not show sclerosis, and secondaries of the cavity, secondary of the temporal bone will appear as cavity, then multiple myeloma, tuberculosis, eosinophilic granuloma. If the cavity is bilateral, when you take an X-ray, last view of both sides, if you see cavity on both sides, it could be a large antral air cell, which is a normal variant. So presence of large antral air cells on both sides again is a normal variant that should be taken into consideration. Then X-ray mastoid, classically it's also known as loss view or lateral oblique view. Here both sides of the temporal bone should be X-rayed. I've already told you to compare the pneumatization, and there should be no overlap of one temporal bone with that of the other side. This view ensures that there is no overlap with the temporal bone one side with that of the other. Thank you so much for your patient listening.